This is America, and this is Philadelphia, one of the host cities of the FIFA World Cup. And with millions of fans flying in from all over the world, just how prepared is the US if there is a major public health emergency? We'll have more on that later in the programme, but first, over to Rob Matheson in our Washington, D.C. studio.
Thanks, Bernard. The US has been bracing itself for the arrival of more than 1 million football fans from around the globe. Among those on alert are medics and scientists. They're watching for the first signs of a possible virus outbreak. Now, the risks are low, but the stakes are high. US health agencies have been hit by funding cuts, and in some cases, leadership posts have been more like revolving doors. And public confidence remains shaky since the US, like the rest of the world, struggled to cope with the virus that defined the first years of the decade.
Now at 6, the coronavirus pandemic. Mayor de Blasio declaring a state of emergency in New York City.
Hello and welcome, everyone. Coronavirus cases out of control in South Florida.
Tonight, it would almost be easier to tell you what hasn't been canceled or closed to keep the virus from spreading.
Millions of people in Tarrant County now will be required to wear masks.
If you are not wearing a mask in Nashville, as of today, you might get stopped by the police.
The FDA approving the Pfizer vaccine for that emergency use authorization.
1 million coronavirus vaccine doses are on their way to pharmacies across the U.S.
Well, the organizations which are in the best place to deal with a major health emergency are grappling with their own crisis, funding cuts. Both the World Health Organization and United States Centers for Disease Control are facing lower budgets, and that only limits their capacity to tackle any potential outbreaks. Here's Bernard Smith.
The stage is being set for the biggest sporting event Philadelphia has ever seen. 500,000 visitors are expected here during the World Cup. Philadelphia is one of 11 host cities preparing for upwards of 7 million fans. But health officials trying to make sure everyone stays safe and healthy are facing challenges.
The team that's been working.
The US has left the World Health Organization. Its funding is now cut by 25%, just as Ebola breaks out in Central Africa. The WHO's ability to give early warning of other disease outbreaks is weakened, while the US Centers for Disease Control has had no director since last August. And a large chunk of the $3.5 billion it got during the pandemic for long-term planning has been clawed back by the Trump administration.
So much of what public health departments across the country have had to deal with is resistance to ideas that have long been settled. So much of what it is that we lost during the pandemic was trust. And it's going to take a long time to rebuild that. Luckily in Philadelphia, the health department has been there doing that hard work of rebuilding trust.
But James has to try and rebuild that trust with a budget that's been slashed because of federal government funding cuts. The most immediate public health threat might be homegrown. In 2000, the US declared measles eradicated. Now it's back. From 2024 to 25, the number of measles cases around the country jumped from 285 to almost 2,300. And there have already been just under 2,000 cases so far this year. The CDC says the spike in cases is because of a drop in routine vaccinations and an increase in post-pandemic international travel. Now, measles is highly contagious and spreads quickly in times of high travel and when people are in close quarters. The US does maintain specialist quarantine facilities, like the one in Nebraska, where it recently sent cruise ship passengers exposed to hantavirus. And with Ebola doing the rounds again, it's diverting incoming passengers from certain countries to 4 specific airports, which are best placed to deal with enhanced screening. And during the tournament, Philadelphia and other host cities will be regularly testing wastewater to make sure football fans are not carrying anything more contagious than enthusiasm. Bernard Smith, Al Jazeera, Philadelphia.
Well, public trust appears to have been hit hard by the COVID pandemic, as well as ongoing controversies around health services. Before the pandemic, 82% of American adults said they had a high level of confidence in the Centers for Disease Control and Prevention. It's known as the CDC. But by 2022, that figure had dropped sharply. It was down to only 56%. It increased slightly 2 years later. But now only 47% say they trust the agency at least a fair amount as a source of reliable vaccine information. That's down more than 10 percentage points since the beginning of the second Trump administration. Well, to talk more about this, we're joined by Dr. Paul Friedrichs. He's a former director of the White House Office of Pandemic Preparedness and Response Policy, and Michaela Simoneau, Global Health Security Fellow at the Center for Strategic and International Studies. Welcome to you both to Al Jazeera. Thank you very much indeed for being with us. Michaela, let's start with you. Of course, the last widespread outbreak was coronavirus. What do you think the lessons have been that have been learned since then?
I think we've learned quite a number of lessons about how chronic underinvestment at the local level and the state level impeded response, how some lack of modernization of capabilities across surveillance, the development of medical countermeasures like vaccines and therapies and tests, and our coordination across our federal response system really impeded the response early in COVID-19 and through the pandemic. We had some measures through legislation from Congress and innovations that mayors and governors push forward that I think were able to deal with some of those coordination and technical challenges as we move through the pandemic. There was this office established at the White House that Paul ran. I think the challenge that we're seeing now is that there's been a restructuring of a number of federal agencies and a reduction in programs and staffing and budgets that have rolled back some of those lessons that we were beginning to learn. And we're now in a situation where maybe there's some sense of calm that this was a once-in-a-century pandemic where, in fact, we know the risks are rising and there is a high chance that we'll be facing biological threats like this in the future, and we're not quite sure when those might arise.
Well, Paul, let's use your former office as an example of this because, as I say, White House Office of Pandemic Preparedness Response Policy was set up in order to be able to deal with this kind of thing. There were 20 people in it initially, I understand. I don't think there's anybody in it at the moment. What do you think that tells us, as somebody who was the former director of it, about the way that the White House is viewing the potential of an outbreak? Do you think that it isn't simply as focused as it should be on the potential, or do you think that if there is something that does happen, it's going to stand back and take a hands-off approach?
So I can't speak for this administration. I'm not going to hazard a guess as to their rationale behind it. I think their decision to de-scope the office or to remove the staff from the office there is similar to what President Trump did at the beginning of his first administration. And as we discovered in January 2020 and certainly by March 2020, we needed a coordinating space, and so they had to create it. This has been one of those lessons that unfortunately we observe with many outbreaks, but we haven't learned. And I think that's the key point, that when we go back and we look historically at almost every big outbreak, we wind up needing a coordinating center. We need someone who can work across the departments and agencies to help bring people together at the federal, state, and local level so that everyone's on the same page and we have a clear plan for how we're going to mitigate risk.
I want to expand on that in a second, but it is worth talking about the kind of messaging and understanding that the public has and who they trust in order to be able to give them that messaging. And there is a disconnect between the trust that Americans have, that they get from care organizations and what they hear on health issues from top government officials. Nearly 90% of them, of course, say that they get information and that they're confident about it from the health that they get from their own doctors and other primary health care givers. Individual organizations also score highly, like the American Academy of Pediatrics, 77% level of trust from the American public, but only 43% say that they trust the public health information communicated to them by leaders of federal agencies. Michaela, why is that split happening?
So we've seen this is historically Americans tend to trust their local health providers and their immediate health providers the most. And that's great. And that's a great way that we can leverage health communications and tailor health communications to what's most important to folks in their local community. We've seen partisanship drive some of this decline in trust in public health institutions over the course of the pandemic and coming out of it. Overwhelmingly, Republicans have less trust in health institutions and the health information they receive from them than folks who align with different political ideologies. But across the CDC and the FDA and some of these other health agencies, it's pretty similar in terms of the decline that you've seen. and the general lack of trust. And I think that's driven by a sense that these agencies have become more politicized over the past several years as we've dealt with the aftermath of the pandemic. And I think we still have struggled somewhat to modernize how these agencies are communicating, meeting people where they are, whether that's receiving information on social media or otherwise, and how we communicate this sense of humility and we're learning with the science and here's what we know at this moment, and communicating that down to local clinicians so that they can be having similar conversations when they get those questions in the doctor's office.
Yeah, the message is clearly important because we saw that during the pandemic, but also, as you referred to, Paul, communication between the agencies as well is equally vital. Do you think that there is still a robustness there in the communication between those agencies, or are we seeing gaps which could cause problems in the event of an outbreak?
So if you look at the history of any large government, there are always gaps in communication. The 9/11 Commission highlighted that as one of the big findings that contributed to 9/11 occurring. And certainly it was one of the things that we highlighted when we looked back at the COVID pandemic. To say that there are no gaps would be, I think, either very naive or very optimistic, but there are clearly still gaps, and that's why it's important that we recognize that and that we deliberately create structures, the command structures, the information sharing, so that we minimize those gaps wherever possible. And I want to just piggyback on what Michaela said, because the effort to make this a political rather than a health issue exacerbates those gaps. If you go back to the 1918 pandemic, which was more lethal, more impactful, killed many more people than the COVID pandemic, you saw exactly the same thing. Politicians taking health-related issues and using them in elections to help get elected. Now, I don't fault politicians for trying to get elected, but I do think we need to recognize that some of what's happening right now are efforts by people to take known challenges and use them to their benefit. If they're really committed to the health of the American public, then the next thing out of their mouth should be, and here's what we're doing to fix those gaps. Here's what we're doing so that we can restore trust, so that we can, as Michaela said, meet you where you are. And I want to give a shout out to our nurses. So you didn't mention it, but on all of those studies, the most trusted voice for healthcare information are America's nurses. And we need to continue to turn to them. When mom is sitting at the table trying to figure out what to do, she needs to go talk to her primary care provider, talk to a nurse that she trusts to get the information. That has historically been where Americans can get great information, and it still is today.
Michaela, you mentioned social media, and picking up on the point that Paul's making, there is suddenly this paradox that we see, this dichotomy in a sense, that the kind of messaging that we get at a senior political level for perhaps the reasons that Paul was talking about, but at the same time, sometimes, and we did see this in COVID particularly, that it runs contrary to the kind of information that medics, people who are actually working on the ground are giving, and that makes it very confusing, doesn't it, for the public? And as a result of that, is there a re-education program, do you think, that needs to be established for the public to re-emphasize where they should be getting the information from?
I think one of the challenges we have here is that folks have such a wide array of information at their fingertips now, and a lot of it is being presented without context, and we have a gap in health literacy in this country, I think, in being able to digest what that research means. I think it can be condescending to say that people can't make decisions based off of the information they have in front of them, and a lot of the times folks want to take their personal circumstances and try to apply that to what they're hearing. And so, like you say, it's about giving people the tools to do that and having more health literacy that we build up from early on in education, and alongside that, literacy in how to deal with social media, and now with the rise of AI-generated content, how do you verify what's true, what's not true, who do you trust, who do you not trust? For our health agencies, a lot of that comes into delivering on promises and having actions that prove that they're trustworthy, and for local and state public health officials as well, delivering on the commitments they've made to Americans, so that'll help bring up the level of trust through that performance. But some of it is, we've seen that folks who use social media they also have a higher propensity to follow claims that have been shown to be misinformation. And so it's how do you judge that information right, and adapting our communication so that we're in this 21st century media environment that is, I think, only going to get more polluted as we go forward.
I think a way of illustrating that, I mean, outbreaks of viruses or illnesses that we're talking about do generate a lot of headlines. At the same time, the context is important. Alex Baird's been breaking down the potential risks.
Let's take a look at the biggest threats American public health experts are looking at right now. Generally, they're focused less on one specific next COVID and more on categories of threat. First off, there are the novel flu viruses. Those are new or significantly changed strains of influenza that have jumped to humans from animals or evolved from a seasonal virus. H5N1 has the highest profile at the moment, and that's common in wild birds worldwide and has caused outbreaks in poultry and dairy cows here in the States, with sporadic human cases. Around half of reported H5N1 cases globally have ended in death. But here, most cases have been mild. The CDC says avian flu viruses have pandemic potential if there's sustained spread between humans, but that hasn't happened yet. Then there are the coronaviruses, which we're all familiar with. COVID-19 was the big one, but before that there was MERS and there was SARS, 3 outbreaks in 25 years. And the reason scientists keep watching them is that coronaviruses circulate in animals, can jump into humans, and if they adapt well to human transmission, can move quickly before health systems know exactly what they're dealing with. And then there are the viral hemorrhagic fevers. Here we're talking viruses like Ebola and Marburg. Unlike influenza and coronaviruses, most aren't transmitted through the air but through direct physical contact. And they're worrying because some, like Ebola, have fatality rates of over 50%. There's an active outbreak in DRC and Uganda right now, and the CDC here has implemented enhanced travel screenings to try and prevent it from entering the US. But the risk here is considered low. Finally, there's the threat with no name yet, what global health experts call Disease X, an unknown or newly emerging pathogen. The CDC has said that it needs to be prepared for the unknown every day, especially when millions of people travel around the world for an event like the FIFA World Cup.
So Alex was talking there about global outbreaks that we've been seeing and the potential risks from those. Our correspondent Bernard Smith in his earlier report referred to the fact that Donald Trump in about January 2025, I think, pulled the US out of the World Health Organization. Now, if I understand it correctly, part of the benefit of that process was that the US, like other member countries, would get early warnings, essentially, from other member countries in the event that there was an outbreak and they could take action. So to what extent do you think removing the US from that line of information has had an impact on the US's ability to be able to respond, Paul?
Yeah, I think it was a mistake for us to withdraw from the World Health Organization. Like many bureaucracies, it has its flaws and it needed to reform, and they have implemented many of the reforms that President Trump called for. But they also provided great service, and one of those things that you mentioned was really important, and that's the ability to see what's happening around the rest of the world. Now, the reality is we have military and other personnel stationed all over the world. We do have other sources of information, but it is not the same as what we're getting from the World Health Organization. And so our State Department now is in the process of negotiating agreements with several dozen countries, and part of those agreements, we believe, will include data sharing that should help us to replicate some of what we were getting from the World Health Agency. But it's a little concerning when we hear the Department of Health and Human Services saying they'll need $2 to $3 billion to replicate what we used to get for $600 million. This is not a trivial thing to replicate this sort of global surveillance. And I think Alex did a great job in his rundown, but I'd add a couple of things to it. One is what Bill Gates touched on in his annual letter this year. The confluence of AI, biotechnology, and rapidly improving computational capacity is making it easier for people to go in and do bad things with good technologies. And that is a growing risk that many of us are concerned about that sort of falls into the Disease X category. But it is one that should cause us to seek more collaboration, not less collaboration, so that we do have that early warning. Another thing that your earlier correspondent talked about is measles, the stuff that happens all the time. There are all sorts of outbreaks that occur around the world. And the WHO was the place where that information was gathered and was shared. And replicating that visibility is going to take time and it's going to take money. And the alternative, which I strongly support, is that we rejoin the WHO and that we work to achieve the reforms that are needed there while regaining access to the information that they provide.
Michaela, I want to pick up on the point that Paul made with regard to AI and get your take on this. I mean, that was an element that I had not considered, but I can see now that it will be a factor. What's your assessment of how that could play into the kind of scenarios that we're talking about?
I think there's some benefits that we can see from the rise of AI and how it could potentially help boost up technologies that we need when we're responding to outbreaks in terms of surveillance and being able to integrate more data streams into that picture. There's also a lot that AI can do in terms of helping accelerate drug discovery, look at a wider array of potential compounds that could be used, and to test existing drugs and see if they would have cross-protection against other diseases that we're trying to find solutions for. But the risks that Paul highlights are very real, and I think you've seen some very good dedication across some of the leading AI labs across testing what these risks might look like, what's called red teaming, and making sure that they have the right safeguards in place so that if you had a bad actor who was trying to use these large language models, that they wouldn't be able to jailbreak those things. I think the more that we've had models advance, the more they've shown capability that they're able to jailbreak those safeguards. And we're not talking about just large language models here that we're all more familiar with. There's also highly specific what are called biodesign tools that you can use to get at some of these really tricky problems like protein folding that have, I think, confounded scientists for a long time.
And if I could just piggyback, that was a great rundown there. Human nature hasn't changed. There's not a technology that exists that bad people have not tried to use for bad reasons. So I don't want to make it sound like AI is unique in that regard. It's not. It is all the wonderful things that Michaela described and more. But we should be very clear-eyed that the threat is not going down, it's going up. And that's, I think, the key point that we need to keep focusing on is how do we collectively identify quickly, mitigate effectively, and then recover, because the economic effects are profound. The educational effects are profound. And then you've got the health effects as well to worry about.
Yeah, I want to pick up on the political element of this that you both touched on earlier. I mean, Democrats haven't been too happy about the way that the Trump administration's position on how to handle possible outbreaks has been metamorphosing. They're particularly angry about how the CDC has been affected. Senator Chris Murphy recently posted on X, this Ebola outbreak, that's been a slow-motion disaster, he said. 900 cases and now threatening the US. We know how to stop outbreaks like this, but Trump chose not to stop it. He destroyed our global health team, deliberately exposing us. And the Democrats' top representative in the Senate says the Trump administration's cuts to health care are leaving the US wide open to another outbreak.
The Trump administration's gutting of America's public health preparedness has made the recent hantavirus outbreak even more alarming. We often say you don't miss something until it's gone. And that's certainly true of the cruise ship inspectors, disease detectives, port health station staff, and other pandemic experts that Donald Trump purged without a second thought. Trump may as well have invited the virus to our shores.
Now, Michaela, one of the reasons that the changes were made at the CDC apparently was to make it more nimble and more responsive to outbreaks. At the same time, the administration has cut, I think, $750 million from grants that states were using in order to help them prepare for disasters and outbreaks. The emphasis shifts to the states, and we were talking about this localization element. How much does that hinder their ability to be able to try and respond?
Some of the most important capabilities that we've built out over the past several years, especially in response to the 2014 to 2016 Ebola outbreak, and I think the wake-up call that represented, have luckily been sustained. So we saw when we had the Americans who were exposed to hantavirus come back to the United States, they were able to go to University of Nebraska Medical Center, where there's a biocontainment unit, a bioquarantine unit. So some of those dedicated professionals and really strong scientific capabilities are still in place. the staffing and the expertise that has been diminished in the United States, and I think in how we extend our U.S. footprint globally is certainly a major challenge. And we're lucky in, if we can say we're lucky, in the Ebola outbreak right now in the Eastern Democratic Republic of the Congo, that we have strong CDC country offices in the DRC and in Uganda, where those staff work hand in hand day to day with the country teams. But as you say, this diminished staff capacity, it really hurts our ability to surge response, whether that's domestically, at the national level, or internationally, as we're dealing with these threats that pop up.
We have just 1 minute left, Paul. Just if you want to pick up.
Well, I think a really key point on that is that one of the lessons learned from the COVID pandemic was that we were able to get vaccines out that saved millions of lives. But we were able to do that because we invested 20 years of research funding into understanding that virus. And we had about 15 years of research funding in the platform, the mRNA vaccine platform. And fortunately, we were able to combine all of that work in order to develop life-saving vaccines. The cuts to research, the repudiation of mRNA vaccines and vaccines more broadly is terribly short-sighted. We should be very clear-eyed that vaccines save lives and that the next pandemic and our response to it will depend on how well we invest today in preparing for tomorrow's outbreak.
We're going to leave it there. Thank you. I want to thank our guest, former Director of the White House Office of Pandemic Preparedness and Response Policy, Dr. Paul Friedrichs, and Global Health Security Fellow at the Center for Strategic and International Studies, Michaela Simoneau. And that's all from the team here in Washington. We're going to hand you back to Bernard Smith. Don't forget the website, of course, aljazeera.com. Then it's Al Jazeera's global headquarters in Doha.
Thanks, Rob. Don't forget you can catch this episode and all our other ones by checking out our YouTube channel. Just search for Al Jazeera English. We'll be back with another edition on Wednesday at 18:30 GMT. That's 2:30 Pacific time here in the United States. Until then, from the whole team here, thank you for watching, and we'll be back soon.